All right, welcome to the Anesthesia Academy. Today, we're jumping into a high-yield, rapid-fire review of some core pharmacology and physiology principles. Think of this as a mock exam session, a way to really sharpen those clinical instincts and make sure that foundational knowledge is rock solid. Let's get right into it.
So here's the game plan. We're going to move fast through 5 key areas. First up, the basics of how drugs get around the body. Then we'll tackle the dynamics of our inhaled agents. After that, we'll get into the weeds on MAC, what it is and what changes it. We'll cover some essential IV drugs and neuromuscular blockade, and then wrap up with a couple of advanced clinical concepts you absolutely see every single day.
So let's kick things off with pharmacokinetics. This is the fundamental story of what the body does to a drug. And for us in anesthesia, timing and location, well, they're everything.
Okay, here's our first clinical puzzle for you. Picture this. You've given a big dose of a fat-soluble opioid, something like fentanyl, during a long case. The main effect seems to wear off, but hours later in the PACU, that patient is still a little sleepy, still showing signs of respiratory depression. What's going on here?
The answer, and this is a huge concept for us, is redistribution. When you push a lipophilic or fat-loving drug, its first stop is the places with the most blood flow, like the brain. That's what gives you that immediate, powerful effect. But then, over time, the drug starts to move, or redistribute, into tissues that don't have as much blood flow, but have a massive capacity to just soak it up. And the biggest one? You guessed it, fat.
And this is the absolute key. A patient's fat tissue basically becomes this giant drug reservoir. So even after you turned off the infusion and the levels in the blood start to drop, the drug just slowly leaches back out of the fat and into the bloodstream. This creates that prolonged, low-level effect like respiratory depression. So it's not really about how fast the body is getting rid of the drug, it's about where that drug was hiding out.
Let's move on to another key principle, and we'll use a classic toxicology question to frame it. You got a patient with a phenobarbital overdose. And remember, phenobarbital is a weak acid. Your goal is to get it out of their system through the kidneys fast. So how do you play with their urine pH to make that happen? Do you go acidic or alkaline?
This whole thing hinges on a concept called ion trapping. The name sounds kind of complicated, but the idea is actually pretty simple. See, drugs can easily sneak back from the kidney tubules into the blood if they're in their non-ionized fat-soluble form. But if you can flip them into their ionized water-soluble form, they get trapped in the urine and, well, they get flushed right out. So, here's the rule of thumb. To trap a weak acid, you make the urine alkaline. By giving something like sodium bicarbonate, you drive up the urine pH. This forces that phenobarbital into its ionized state, which means it can't be reabsorbed. It's stuck. And this just dramatically speeds up its excretion. And of course, the exact opposite is true for a weak base. You'd want to acidify the urine to trap it.
Okay, let's switch gears and talk about our inhaled anesthetics. With these agents, it's really all about physics. That's what governs everything, especially how quickly your patient goes to sleep and, just as importantly, how quickly they wake up.
So when you turn on that vaporizer, what's the single most important property of that gas that's going to determine how fast your induction is? I mean, is it how potent it is? Is it the vapor pressure, or is it something else entirely?
And the answer is the blood gas partition coefficient. Now, this is one of those things in anesthesia that feels totally backwards at first. For a fast induction, you actually want a gas that is insoluble in blood. Think about it like this. Blood is like a sponge. A really soluble gas gets soaked up by that sponge as it passes through the lungs, and that prevents the pressure of the gas from building up in the lungs, which is what you need to drive it into the brain. An insoluble gas, like that's fluorine, it barely dissolves in the blood at all, so its pressure in the lungs just skyrockets, and boom, you get a super fast induction. So if low solubility is what speeds things up, what slows things down? Well, a huge one is increased cardiac output. If the heart's pumping more blood through the lungs every minute, it's basically a bigger, faster sponge, just yanking more and more anesthetic away from the alveoli. This slows down how fast the alveolar concentration can rise, and that delays your induction. And this effect is way more pronounced for those highly soluble agents, because there's just so much more drug for all that extra blood to carry away.
All right, on to section 3. Let's talk about MAC. This is our bread and butter, right? The fundamental unit of measurement, the yardstick for the potency of our inhaled anesthetics. We use this concept every single day.
The definition is super specific, and it's one you've got to know cold. 1 MAC is the concentration of gas down in the alveoli that prevents movement from a surgical incision in exactly 50% of patients. It's an ED50. So think about that. If you're running your patient at exactly 1.0 MAC, you're literally flipping a coin on whether they'll move. And you don't want to run your OR on a coin toss, right? That's why we almost always aim higher, somewhere around 1.3 MAC, which gets us coverage for about 95% of the population.
Now, MAC isn't some fixed number. It's dynamic. It changes with your patient's physiology. Think of it like a seesaw. On one side, you have things that rev up the nervous system. High sodium levels, a high temperature, or the tolerance you see from chronic alcohol use. All of these things will increase the MAC. You're going to need more gas. On the other side of the seesaw, you have things that depress the system, like increasing age, being cold, acute intoxication, or adding other drugs like opioids. All of those will decrease the MAC, meaning you need less gas to do the job.
Okay, let's switch gears again. We've talked gases, now let's get into our intravenous agents and the absolutely critical task of managing and monitoring neuromuscular blockade.
So here's a scenario you will face all the time. You have to induce a patient with a really sick heart. They're fragile, hemodynamically unstable. What induction agent are you reaching for to keep their blood pressure and heart rate right where they need to be?
The answer here is etomidate. I mean, while other agents like propofol can cause some serious vasodilation and tank the blood pressure, etomidate is famous for being cardiostable. It has these minimal effects on heart rate, blood pressure, and cardiac contractility. That makes it an absolute workhorse for inductions in trauma patients or cardiac patients, any situation where every single beat and every millimeter of mercury really counts.
Now let's talk neuromuscular blockers for a second. Knowing how to tell a phase 1 block from succinylcholine apart from a non-depolarizing block like rocuronium is absolutely essential for safety. And the key difference comes down to one little word: fade. When you use a train of force stimulus, a phase 1 block just reduces the height of all 4 twitches equally. There's no fade. But a non-depolarizing block causes a progressive weakening of those twitches. That's the fade you're looking for. And crucially, if you give a reversal agent like neostigmine, it'll actually worsen a phase 1 block, but it'll reverse a non-depolarizing one. Knowing that difference is just key to safe patient management.
All right, for our final section, let's wrap up with 2 high-yield clinical monitoring concepts that you are staring at all day long on your monitors, providing critical, real-time information.
Your capnogram is so much more than just a number. Its shape tells you a story. A normal waveform has that nice flat top, right? The alveolar plateau. But if you see that plateau start to slope upwards, looking like a shark fin, that is a classic sign of expiratory airflow obstruction. It means air is having trouble getting out of the lungs. Gas from slower emptying parts of the lung with higher CO2 just keeps trickling out, causing that reading to steadily climb. And the most common cause you'll see for this? Bronchospasm.
And finally, let's talk about what happens when a patient stops breathing. During apnea, the body keeps producing carbon dioxide and it just builds up in the blood. The rate of this rise is pretty predictable, and it's really important to know. In that very first minute of apnea, the PaCO2 will jump by about 6 millimeters of mercury. After that, it settles into a slower, steadier climb of about 3 to 4 millimeters of mercury for every minute that follows. Knowing these numbers helps you anticipate what's coming and manage those airway emergencies.
So, to wrap up this rapid review, what have we hit? We've reinforced that low blood solubility means a fast induction. We've seen how redistribution into fat is the reason those lipophilic drugs like fentanyl can have such lingering effects. And we've confirmed that MAC is our go-to standard for potency, but it's a dynamic value that we have to adjust for every single patient.
And that brings us to the end. So I'll just leave you with this one final question. Think back to your last clinical shift. Which one of these principles, whether it was redistribution or ion trapping or blood gas solubility or one of those factors that modifies MAC, which one directly changed how you actually managed a patient? Because connecting this theory back to what you do every day, that's how we truly master our craft.